Hyperparathyroidism is increased parathyroid hormone secretion, occurs in older adults, 2 times more common in women. Primary hyperparathyroidism is hyperplasia or tumor of one of the parathyroid glands, increasing the absorption of calcium in the GI tract. Secondary hyperparathyroidism is gland enlargement due to chronic hypocalcemia in the presence of elevated parathyroid hormone. Tertiary hyperparathyroidism, parathyroid glands are enlarged and do not respond to changes in serum calcium levels, usually associated with chronic renal failure. The pathophysiology, increased reabsorption of calcium, bone releasing calcium into the blood, and increased excretion of phosphate leads to hypercalcemia and hyperphosphatemia. Kidneys increase the bicarbonate excretion and decrease the acid excretion, leading to metabolic acidosis and hypokalemia. Bones increase the rate of calcium and phosphorus release, leading to bone decalcification. This all leads to hypercalcemia. Hypercalcemia causes calcium deposits in the soft tissues, renal calculi or kidney stones, altered neurologic function with muscle weakness and atrophy, altered GI function with constipation, abdominal pain, anorexia, and altered cardiovascular system. Clinical manifestations include polyuria, which is an early sign, renal calculi, anorexia, constipation, nausea, vomiting, abdominal pain, generalized bone pain, pathologic fractures, muscle weakness, atrophy. In 55% of patients, renal damage can occur. Calcium buildup can lead to obstruction, pyelonephritis, and possibly renal failure. Nursing diagnosis for hyperparathyroidism include risk for injury, pain, impaired physical mobility, risk for altered urinary elimination, risk for constipation, and deficient knowledge. Therapeutic management. Overall, your goal is to decrease serum level of calcium, normal saline infusions, diuretics, phosphate replacement. Phosphates replacements will decrease the serum calcium levels, and it is for short-term use. You want to make sure your patients are up and moving, weight-bearing exercise. Bones subjected to normal states give up less calcium. Surgery to remove involved parathyroid glands. There are certain criteria that must be met. It's listed on page 1273 in your textbook. You do not want your patient on bed rest. Bed rest can increase calcium excretion and increase risk for renal calculi. Promote comfort, decrease risk of falls, walk with walker if necessary. Strain all urine, provide 2,000 to 3,000 ml of fluid daily as tolerated. Cranberry juice, high fiber diet, pace activities with rest periods, promote nutrition, daily weights, prevent tetany by early diagnosis and recognition, watch for numbness and tingling around mouth and fingertips, muscle twitching of extremities, change in voice, positive Trousseau's sign. Medication therapy includes analgesics to control pain. Diuretics, no thiazide diuretics because they decrease the renal excretion of calcium, therefore your calcium levels remain elevated. Normal saline for IV fluids, phosphate supplements, we talked about that. And then when you're talking about patients having constipation, you encourage increased activity, increased fluids, stool softeners, and prune juice. Hypoparathyroidism causes low calcium, so hypocalcemia. Hypocalcemia raises the threshold for excitability in nerve and muscle fibers, causing the fibers to be easily stimulated and could lead to life-threatening tetany. Clinical manifestations include abdominal pain, nausea, vomiting, diarrhea, anorexia, anxiety, headaches, numbness, tingling, tremors, muscle spasms, difficulty swallowing, hoarse voice, sensation of tightness in throat, dry, thin hair. Tetany is described as general muscle hypertonia, which equals tremors, numbness, tingling, and cramps. A deficiency of the parathyroid hormone equates to increased phosphate and decreased calcium. There is also decreased intestinal absorption of dietary calcium and decreased resorption of calcium from the bone. I think I said dry, thin hair, patchy hair loss, and rigid fingernails. Just wanted to make sure. Therapeutic management, supplemental calcium and vitamin D. Promote comfort and safety, may need to walk with a walker to prevent falls. Encourage progressive activity. Promote nutrition. Medications, calcium supplement, or may need IV calcium gluconate. Vitamin D to promote intestinal absorption of calcium. High calcium and high vitamin D diet. Cheese, turnip greens, almonds, beans, peanuts. No milk or egg yolk because of the increased levels of phosphorus. If your patient is experiencing tetany, tetany requires an environment free of noise, drafts, lights, and sudden movement. Tetany can develop when calcium levels are at a low of 5 to 6. I think that's it for hypoparathyroidism. Okay, Cushing's disease is a cluster of clinical abnormalities caused by excessive adrenocortical hormones, particularly cortisol. The functions of glucocorticoids or cortisol remain. They promote glucogenesis, maintain serum glucose levels, adapt to stress, and augment the release of catecholamines to increase blood pressure. Caused by adrenal tumors, adrenal hyperplasia, the ectopic production of ACTH from a tumor. Who's most at risk? Women ages 20 to 40. Primary cause is benign or malignant adrenal tumors, which stimulates an increased production of cortisol. Secondary, disorders of the pituitary or hypothalamus, which causes an increased release of ACTH. Basically, the pathophysiology behind Cushing's disease is that you have excess circulating ACTH. Cortisol excess results in anti-inflammatory effects and excessive catabolism of protein and peripheral fat to support hepatic glucose production. There's no normal secretion of ACTH and cortisol. No longer able to increase cortisol secretion in response to a stressor. Clinical manifestations include the moon face, buffalo hump, purple striae, truncal obesity, slender arms and legs, changes in personality, hyperglycemia, hypertension, GI distress, like a peptic ulcer from increased acid production, osteoporosis, sodium and fluid retention, changes in secondary sex characteristics, acne, kyphosis, backache, disturbed sleep, oily skin. right, therapeutic management may include a combination of radiation, drug therapy, and surgery. The goal is to suppress the ACTH by the pituitary glands. Octreotide or sandostatin will decrease cortisol levels. A drug called meturaprone will suppress cortisol secretions. That's METURAPONE. Radiation to the pituitary gland may suppress the ACTH production. Assist your client to achieve fluid, electrolyte, glucose, and calcium balance. Daily weights and I's and O's. Promote safety. Uncluttered walking area, adequate lighting, assistive walking devices, non-skid shoes and slippers. Pace activities to avoid fatigue. Prevent infection. Assist with coping strategies. Pre-op care. Ensure your patient understands the planned surgical procedure, post-op routines, and expected outcomes. Post-op care. Promote effective breathing by turning, coughing, and deep breathing. Explain mouth breathing necessary because of post-op nasal packing after a transsphenoidal surgery. Assist with turning Q2 hours. Encourage dorsiflexion of ankles hourly to prevent DVTs. Promote wound healing by minimizing stress on incision. Patients who have had an adrenalectomy should log roll side to side to sit up and do reverse to recline. Transsphenoidal patients should avoid nose blowing, sneezing, or coughing. Elevate the head of the bed to 30 degrees. Let's see. Patients need to, or you as the nurse, need to prevent an Addisonian crisis. Patients with Cushing's who have a withdrawal of corticosteroids or an adrenalectomy or a pituitary tumor removal are at increased risk for adrenal hypofunction. Addison's crisis is very similar signs and symptoms to that of shock. Decreased blood pressure, increased pulse, decreased level of consciousness, anorexia, weakness, dry tinting skin. Let's see, I think I covered all of it for that slide. Addison's disease is chronic adrenocortical insufficiency, as there's been some destruction of the adrenal glands. Who's at risk? It's more common in women over 60. Immunological factors, surgical removal of the adrenal glands, infection of adrenal glands, tumor of adrenal glands, head trauma that affects the pituitary gland, withdrawal of glucocorticoids or ACTH. Pathophysiology, there's a gradual destruction of adrenal cortical tissue, hypofunction of the adrenal gland, insufficient hormonal secretion of mineralocorticoids and glucocorticoids, deficient aldosterone, cortisol, and androgens. Insufficient aldosterone leads to a reduction in sodium absorption and increased sodium excretion. Water follows sodium, leading to increased water excretion and hypovolemia. Hypotension occurs. Potassium is retained as it moves opposite of sodium, resulting in hyperkalemia. Clinical manifestations include depression, hypotension, EKG changes, weakness, fatigue that worsens throughout the day, skin hyperpigmentation, that bronze look or eternal tan, delayed wound healing, diarrhea, nausea, vomiting, anorexia, decreased libido, hyperkalemia, hyponatremia, hypoglycemia, weight loss, Addisonian crisis, we talked about that a little bit on the last slide, often occurs as a result of sepsis, trauma, surgery, omission of steroid therapy, or some acute physiological stress, profound weakness and fatigue, nausea, vomiting, dehydration, hypotension, and confusion. Nursing diagnosis for Addison disease: deficient fluid volume, risk for ineffective therapeutic regimen management, deficient knowledge, risk for electrolyte imbalance. Oh, that's it. Sorry, I was on a roll. Therapeutic management. For Addison's disease is replacement of corticosteroids and mineral corticoids, maintain fluid and electrolyte balance, daily weight, encourage 3 liters of daily oral intake and added sodium in diet, promote safety, walking assistive devices, adequate lighting, clear area for walking, appropriate shoes and slipper, and medications, hydrocortisone or Cortef to replace glucocorticoids, and Florinef to replace mineral corticoids. Okay, so that thankfully wraps up endocrine. Please take lots of notes, write down your questions, come prepared on Thursday to discuss your questions. And then we're going to do some class activities, so please be prepared to participate in those class activities. Make sure you bring all your notes and everything to class, and I will see you then. Thanks.